Hey everybody, hope you had a great week. So I have acoustic neuroma today. What is acoustic neuroma? So it's also known as vestibular schwannoma, and it's basically a tumor that grows in the ear. It's benign and usually slow growing, although it can grow rapidly, but that's pretty rare. It develops on the nerves connecting the inner ear to the brain. It can affect both hearing and balance nerves depending on the size of it. It can also affect the um, trigeminal nerve, which is the facial nerve. It's usually unilateral, but it can be bilateral. So some signs and symptoms, 90% of patients with this disorder experience hearing loss. Another common symptom is tinnitus, ear fullness, unsteadiness or loss of balance, vertigo, facial numbness, weakness or loss of muscle movement in the face. It can also cause like sudden rapid movements in the muscles of the face, like twitching. And then these last ones are more on the rare side, but this disorder can also cause swallowing problems, a change in the patient's ability to taste and their ability to produce tears, and it can also cause headaches and pressure on the head. Okay, so some statistics. There's two types of acoustic neuromas. You have a unilateral and bilateral. Unilateral is accounts for 8% of all tumors that occur in the skull. This is not hereditary. The incidence is 1 in 100,000 individuals per year, and it usually occurs between the ages of 30 and 60 years old. Bilateral acoustic neuroma is hereditary. It's a genetic disorder that is associated with NF2, a genetic disorder, neurofibromatosis, and it usually occurs in teenage years or the patient's early adulthood. But both types of this disorder affects men and women equally. And then etiology and pathology, site of lesion, so it's affecting the nerves of the inner ear. It's believed to occur from the loss of function of the gene on chromosome 22, which this chromosome is responsible for producing protein that controls the growth of Schwann cells. So with the loss of function, there's going to be an overproduction of the Schwann cells, which is what the tumor grows from. And Schwann cells are cells that wrap around nerve fibers to help support and insulate the nerves. But with too many of the Schwann cells being produced, it can result in a tumor. So to diagnose this, the audiologist will perform otoscopy and then basic hearing and balance tests. So an audiogram, an electronystagmography, an auditory brainstem response, and MRI scans. MRI scans are really important. They're critical for early detection of the tumor, but they're also used to determine how big the tumor is, where it's located, which will later on affect if the patient decides to go through with microsurgical removal. The MRI helps to plan out that surgery. And then there are 3 treatment options for this disorder. So you have surgical removal, radiation, or observation. A surgical removal is used to excise the tumor. And then depending on the size of the tumor and the effect that it has on the patient's hearing will determine how the surgery is performed. If the tumor is small, hearing can be saved and symptoms can be relieved. But if the tumor is rather large, then surgical removal can be pretty risky because it poses a risk to injuring the nerves of the ear. And so this can cause hearing loss. The surgery itself can cause hearing loss to the patient, and it can also make the symptoms worse. So if the patient decides not to get the surgical removal, they can get radiation instead. So this radiation is used to reduce the size of the tumor and also limit the growth of the tumor. And then this is more preferred for individuals that maybe don't have the best hearing already. So individual like elderly patients, maybe patients with poor health, or patients that have a bilateral diagnosis, since the surgery poses a risk of causing hearing loss if the patient has a tumor in both ears. Radiation might be preferred so that they're not putting the patient's entire hearing ability at risk. But then if the tumor is small and it seems to be not growing, then some doctors might just recommend observation, which is just the patient getting just having MRI scans done pretty frequently just to keep track of that tumor and to make sure that it's not growing and not causing any complications. And then I have a video here of a patient who was diagnosed with acoustic neuroma, and she talks about some of her symptoms that she had and some of her lasting symptoms after the surgery.
Hi, my name is Hayla Kelch, and I am 27 years old. I was diagnosed with an acoustic neuroma 2 years ago. It's 5 centimeters large, and my story is pretty unique, I think, because I actually diagnosed myself while I was in medical school. I was studying for my medical board exam, and I noticed that I had nystagmus, which is when your eyes jump when you look to the sides. And I knew from studying that that meant some sort of intracranial problem. So I got super freaked out and had an MRI and discovered the tumor. So I was correct, which I was pretty excited about at first, but then quickly realized that that meant a long road of treatments and surgery. So I got quite scared after that. I actually had not a long time in between diagnosis and treatment because my tumor was rather large. And so I had my first craniotomy, retrosigmoid approach, microsurgery, just 3 weeks after diagnosis. So I really didn't have much time to research different doctors or different treatments because the neurosurgeon basically said, you're going to die sooner rather than later. So that really actually scared me. I had the surgery, 13 hours long, and then the subsequent MRIs showed that they didn't get it all or much at all of it. So 4 months later, I had to go back for a transubranthine microsurgery in the hopes of removing the rest of it. That was 21 hours long. So I think for my family, that was the hardest part, is just waiting that entire time. I was asleep. So and after that, I had multiple pulmonary emboli from deep venous thrombosis that I got from my inactivity while being in the hospital. So anyway, there was some complications and some extra treatments for that. And during this whole time, I had to take a year off of medical school so that I could recover. And I just want everyone to know that after this 1 year, I still have permanent hearing loss on the right side where my tumor was located. And I do, as you can see, have facial paralysis. But with reconstructive surgeries, I have a gold weight in my eyelid to help it close entirely. I'm also getting facial reconstructive surgery so I can start to smile. I still have one more surgery in 3 months that hopefully will correct that And I also have a Baja hearing aid that helps with sound conduction. So when I'm in surgery, I can hear the surgeon talking next to me, even though our mouths are covered with masks. So it's quite helpful. So I was scared about how this would affect my future career. But after my year off and these extra surgeries, I'm back exactly where I was before with these problems that I'm adapting to, which really don't harm me at all in my life and in my career.
Okay, so yeah, that's just an example of a patient who experienced this disorder. And then here are my references. Have a great week, everybody. Bye.